Healthcare is supposed to be for everyone, but the reality is that it's not equal. Women, people of color, and other minorities frequently experience lower standards of care. This is largely due to epistemic injustice, which is defined as prejudicial discrimination against a person based on assumptions about their capacity as a knower. And its more specific definition, testimonial injustice, which occurs when prejudice degrades the credibility of a person's word as a knower due to the bias of the hearer. There are a multitude of reasons why bias happens, but when it comes to testimonial injustice as a catalyst for lower standards of care, the headline is that women are not believed. And when patients are not believed about the symptoms they are having, nor empowered to make their own informed choices, treatments are imprecise at best and harmful at worst. Here are just a few cases where testimonial injustice causes harm. In one 2008 study, it has been found that among abdominal pain patients in the emergency room, women are less likely to be prescribed opioid painkillers than men, and face longer wait times for that medication than men. As a result, women are subjected to more overall suffering as they stand by and wait for painkillers that never come and are often of lower strength than those prescribed to men. Not only can this result in medical trauma, but it can negatively affect health outcomes, as severe conditions may go unchecked due to pain levels that are not perceived as severe enough by healthcare staff. This is likely caused by prejudicial stereotyping. Perceived as over-emotional, reports of pain from women are historically downplayed by their healthcare teams, making their pain management seem lower priority. In a 1990 study, evidence has shown that, in addition to being less frequently given medication for their pain, women were also found to be more often prescribed sedatives meant to quell anxiety, while men received painkillers for the same complaints. This further exacerbates gender inequalities in medical treatment, as the replacement of pain medication with sedatives can result in less lucidity, causing even further testimonial injustice for women, as they will be too lethargic to report symptoms of possible complications and less likely to be taken seriously if they do manage to say anything at all. Perceived as hysterical and over-anxious about their pain, women are more likely to be deemed emotionally unstable, needy, and unable to cope with stressful situations, resulting in treatments that emphasize mitigating anxiety rather than treating the root cause of the distress, which is pain. In her 2021 article, Sarah Cohen-Chabot recounted her harrowing experience of what she calls obstetric violence and dehumanizations, where during childbirth, her knowledge of her own body was dismissed, her consent for invasive vaginal examinations was not requested but rather demanded, and her personhood as a decision maker was devalued by medical staff in the delivery room. The results of these attitudes is archaic standards of ethics for obstetricians, emphasizing a more paternalistic approach to healthcare than is widely accepted by bioethicists, waiving women's rights to true informed consent, imposing preferences and pressures upon them without knowledge of their individual experiences, and ultimately taking away their body autonomy in a time of vulnerability. This is likely a result of women being perceived as less objective and qualified to understand their own needs due to irrationality during childbirth, as well as a belief that in times of medical urgency, even when the patient is fully lucid, education on treatment options and consent is unnecessary. In a 2021 study, clinicians identified signs of linguistic bias in patient medical charts, finding alarmingly that dismissive language such as the use of patronizing quotes, judgment words, and suggestions of doubt towards patient testimony is more common in patients who identify as female at 58%, paired with significantly higher instances of women's charts containing quotes. This kind of biased language can result in a poor doctor-patient relationship right on first impression, as clinicians are more likely to judge a person's behavior based on the impressions of their colleagues rather than at face value, due to their perceived higher level of qualification in relation to the patient. This leads to a kind of prejudice that reverberates through a patient's experience, passed on from healthcare worker to healthcare worker, worsening the degree of testimonial injustice a patient experiences over their entire medical career. This is likely a result of judgmental stereotyping. Perceived as overdramatic, women's testimonies about their medical problems are systematically downplayed due to a culture of encouragement towards disbelief of patients' testimonies in healthcare settings, in order to prioritize people who genuinely need help over people who are exaggerating symptoms in order to get prompt medical attention. When testimony is downgraded and capacity as a knower is invalidated, this leads to several main harms. The first harm is lower ethical standards of care, which leads to increased paternalism from doctors, taking away women's rights to informed consent, and falling in several bioethical pitfalls. The second harm is lack of diagnosis, inaccurate diagnosis, and slower treatment response times on the part of clinicians, which in medical emergencies can lead to poorer treatment outcomes, permanent disability, medical trauma, and even death. The third and most systemic harm of epistemic injustice is internalized ableism, which is defined as a warped sense of trust in oneself to understand their own body and limitations, which can lead to underreporting or even ignoring concerning symptoms and disability, further marginalizing women as figures of hysteria and resulting in future reluctance to attain medical care and proper support, resulting in worse outcomes and lower quality of life. These harms ultimately result in a denial of adequate and autonomous assistance that addresses the patient's personal choices and individualized support needs. When doctors downplay symptoms and women lose trust in their ability to report on their own bodies, support is not forthcoming, nor is it accurate, leading to a trifecta of inequitable struggles where patients lose rights and supports meant to combat illness-based inequality. Even when women do ultimately lift the veil of internalized ableism, they end up with no support, forcing them to go on pilgrimages just to find doctors that will not subject them to testimonial injustice, paternalism, and gaslighting about their health, taking time and money they don't deserve to lose to prejudice just to find a doctor who will give them adequate care. This has been a short explanation of why testimonial injustice against women is a major problem in medicine, and until strategies are put in place to combat the lack of confidence in female patients from their doctors, women will continue to suffer all over the world, simply because no one can say, "I believe you."